Hello, good morning, and welcome to our third of our webinar series of implant threads. And today we are joined by Wael Gerges, who is a specialist prosthodontist. He is clinical director at Devonshire House and a specialist in prosthetics. He provides general dental care for a broad patient base and is a specialist prosthodontist again. This is the third time in his bio that he sent me that he said this. He's especially skilled in replacement of missing teeth, the restoration of natural teeth, and in complicated and simple restorations of the whole mouth. Well trained at King's College Hospital Dental School in London, and went on to complete an MSc degree in conservative dentistry at the Eastman, where he is now taught thereafter as a clinical lecturer. Wael went on to teach at the International Centre of Excellence in Dentistry on the Implant Certificate course. He is a member of the ITI, for whom he is a clinical lecturer, and Wael joined the Devonshire House in 1998, to which he's now as a clinical director. So Wael, we're going to be talking about full arch today, so I'll let you load up your presentation and we'll take it from there.
Thank you, John. You just covered the first two slides of mine, so
No problem. Happy
that's
to help.
ideal. Absolutely. Let me share. Tell me when you've got it.
Yes, we can see.
Cool. Right, I'll just tell me when you need me to swap these slides.
That's all right. So if you go into your the presentation mode, the one at the bottom, so that we can just see everything, that'd be great.
Have you got it now?
Yeah, I can see yeah, I can see that. We just need to press the slideshow button.
I've done that. So I'm in
Yeah.
slideshow myself.
That's fine. As long as you can go through the slides,
yeah,
we should be okay with that.
As long as you can see them.
Yes, I can see them. Yeah, we can see.
Okay, great. Would you like me to start now?
Yes. Oh, and just as for our delegates as well, if you've got any questions, please pop them in the chat and we'll go through them as well lectures.
Right, thank you very much for joining us this Saturday morning. I've been very honoured to be asked to talk about immediate full arch load. So I thought I'd go through a little bit of history of it, leading to how we do it, and then just three cases which should spark some discussion, I hope, and then some failures and what we're seeing nowadays, but mainly about full arch and are we doing the right sort of thing. So as John said, I'm at Cambridge Devonshire House Dental Practice and at the Eastman teaching there at the moment. And I graduated at King's, did some Max Facs, conservative dentistry, and then joined. But the main thing is we started full arch loading in 2005, which I've got cases from. So the aims are to really talk about and review the principles of full arch loading, planning, looking at CT scans, and really look at guided surgery, surgical and restorative stages, and compare full arch to other treatment options. There's an awful lot to go through, so bear with me. Now, we all started with this sort of phrase, Brandemark saying no one should die with their teeth sitting in a glass of water, and that's the basis, basically, of immediate full arch loading, really. This is the dream. So one of our original bridges, this was done at the practice at Devonshire House well into the 90s, this is how it started, with bicortical stabilization with the old Brandemark implants. In the initial protocol was leaving them buried for 6 months and then
sorry, Wael, we're still just on your first slide.
Does it work how does this?
If you click on the slide itself.
Yeah. Is it going now?
No.
Okay, let's escape.
I can see you. There you go. That's it. That's it.
So, okay.
There we go.
Sorry, guys. Is it full screen for you?
We can see your we can see PowerPoint. That'll do.
So I keep it on this view?
Yeah, that's fine.
Okay. So there's our Brandemark. This was the original bridge. You can see that bridge, John? You can see that
Yes,
slide.
yes.
Okay, great. So that was our original bridge, what we used to do well into the 90s at Devonshire House. So they had great long-term predictability. We know it works. We know osseointegration works and the restoration aspect works as long as it's done right. But really, what we're going through now is this. No, it doesn't actually work. Let me see. Can you see this as full screen, guys?
Uh, just we yeah, we can see the OPG.
Okay. Can you see? Right. Well, basically, I have a. Let me see if
So,
we can
yeah,
get
if you
this.
click that button there,
I've got that. Does that
that
work for
should
you?
open it up.
I've
No more
clicked
than
it.
what you can see. Yeah,
I've clicked it. So I've got just a picture of the OPG.
yeah,
And now can you see the title?
yes.
So we've got full arch immediate loading, and that's not a great acronym for what we're trying to do because it basically just says fail. So really, we go to it's generally called immediate full arch loading, which this is the protocol that we're trying to go for. This is the end result, which is what we're looking for every time. The concept started it by Krakmanoff in 1990 and then developed by Paolo Marlo. And then long-term studies showed that this is a viable treatment option for a lot of people. So the concept is effectively 4 implants in the maxilla or the mandible to rehabilitate, avoiding posterior regions like sinuses and nerves, 30 to 45-degree angulation of the distal implants with a fixed surgical guide, cantilevers when required, immediate function, all the things that we were taught wouldn't work right at the beginning, but they seem to. And then a low-cost acrylic bridge. Now, it can be done flapless or with a flap. I don't generally go flapless at all, but there are lots of digital systems that allow us to place these implants in exactly the area that we want. With the rehabilitation goals, we want high success, a simple procedure, immediate replacement of failed teeth, immediate function, good aesthetics and function, and very simple to maintain, but mainly economical. There are many, many variations on the theme. Every company is coming out with their own theme and calling it slightly different, but really everything that's exceptional requires a lot of work, as said by Paul Graham, who's an entrepreneur. And it's true, this is not an easy procedure. Now, the studies, I'm going to quickly go over these because it just shows that this procedure works. And for the maxilla, the edentulous maxilla with implant supported prosthesis, it's an option. Now, we can have it supported on 4 implants or on all or conventional on 4 or 6 axial implants, but use of mini implants is inadvisable. The success rate is great. It's in the 90s and prosthesis 100. I have to be honest, we don't get that success rate. We're seeing a lot of issues, but we'll go on to that later on. There are many studies by Brandemark Centers of Excellence, cumulative societal studies showing that over 5, 10, even 10, 15 years, the success rate is really good. But there are a lot of studies that actually, as you can see here, don't go on for that long. And they're also using a variety of different implants from Nobel Active, which is what we use nowadays, from the original Brandemark Type 3 to the Speedy Groovies, all an evolution of the type of implant you can use for immediate loading. But what are we trying to replace? So I thought we'd just classify. So using the MISH classification, the FP1, fixed prosthesis 1, just replaces the teeth, as we can see here. The fixed prosthesis 2, basically a little bit of tooth and soft
You just
tissue
need
and
to
hard
move
tissue
on your
loss.
slide. Sorry, well, you just need to move your slide on. Apologies.
That's all right, John. I'm pressing the button, but it doesn't seem to.
There
Let
we
me
go.
just. Right, if I press this again, yeah, that works for you.
No, it's the same one that you just clicked on. Apologies.
That's okay. I don't know
Yeah.
why that's not working. I'll leave it at this in this view actually, because everyone can
Okay.
see that. I think if I minimize that, um, so yeah, FP3 is longer teeth with a little bit of hard and soft tissue loss, and FP3 here is a lot of tissue loss, which is what we're going to be focusing on today. Our surgical goals, grafting. Now everybody knows me. Knows that I do an awful lot of grafting because bone is always missing, and that's one thing I can't get enough of. Yes, we avoid the sinuses or the vital structures, and we try and keep it as one-stage surgery with a systematic protocol. There are easy steps to follow. Our surgical goals are that we need high primary stability, which that's partly the type of implant you're going to be choosing for this case. But also looking at the restorative aspect, we need to know that we've got enough space for our our restoration long term, depending on the type of prosthesis that we're going to be providing. But one of the most important things is the transition line, the line where the prosthesis meets the gingiva, and having that hidden underneath the smile line for an FP3. So there's various space requirements required from an FP1 to 2 to 3, increasing in height for each prosthesis. Our prosthetic goals are to produce something that's long-lasting, functional, to eliminate these sorts of breakages, have simple wear and tear maintenance, because things won't last forever, but we need some way of repairing any of our prostheses. And we want to offer these immediate function and restore confidence. But the most important thing from my point of view is to have a backup prosthesis, something that we can have if anything goes wrong and we have to retrieve. To prevent things like this is one of those ones that is just planned completely wrong right from the beginning. It's from the smile line to the amount of bone reduction, and maybe this shouldn't have been done in the first place. So are we actually, one thing I'm quite worried about is, are we driving patients to this sort of treatment? I see more and more clinics offering this as their only treatment option. Are patients given the full knowledge? Are they tempted by offers? Or are we swayed by social media? This is a big thing nowadays. So I went onto the internet just as a search, and there are loads of these adverts encouraging people. Now we just got to think, are people aware of what they're getting into with this sort of thing? Or is this the one-stop shop where if you come in, this is the treatment of choice? And I think people need to be aware that there are other treatment options. Our concerns are they fully informed? Do they know that they're not getting teeth back? I always tell my patients that, if you have a leg removed, we can give you a leg back, a prosthesis, but it's not your leg. It's the same with this. It won't be your teeth. It is a prosthesis. And it's important that they know this. And also, do we rush into treatment too fast? Are we being properly educated in what the prosthesis, what's requirements of what we need to do? Are we being properly educated? And does money play a part in the decision making, which it shouldn't do? And then what happens next? Nothing lasts forever. So the long-term consequences are when these sort of things fail, or there's an implant that fails, what do we do from there on? And do we need our need for followers affecting our judgments? This is one thing I saw on Instagram years ago, and there were likes with this. People were liking this. And I just thought, really, do we need to be posting this sort of thing? I don't think it's very good at all, really. But we need to ask, what happens when we remove all this bone? Especially for the vertical loss for an FP3, we're removing an awful lot of bone. We're not going to get that back. And what about the cleansability? What about when people get older and they can't clean? How do we maintain them? Is it the right decision? And we have to look in the mouth and look at the patient for clues. This gentleman came into my practice requesting an all-on-4, and you could make an argument that you think absolutely, because the teeth are failing, there's a decent amount of bone, but this here is what concerned me. That was just calculus. John, I'm just going to try and see if we can you see that slide picture by picture?
Yes, I can see 3 pictures overlapped.
Okay, so my slideshow isn't actually working. So it's 3 pictures. If I try and move them, this is basically what we saw with the patient. So a lot of calculus. And I think, well, if I were to place a all-on-4 fixed prosthesis, this will collect again if you can't clean that way. So what can I do to help? So we've tried risk profile. We check the patients. We see what's out of our control and what's in our control. Can these factors be controlled or not? There are patient factors, mouth factors, and site factors, as you just saw. And this would have worked a little bit better on the bigger screen. So I do apologize if I maximize that. There are the boxes, the items surrounded by the red boxes are things that are out of our control. that are patient determined. We cannot control these. These are out of our control, and these can affect patients and long-term success of implants. But what we do, how we do anything, is how you do everything is our goal. Now, this gentleman turned up in our practice as well. You can see the bridge has de-cemented from these abutments, and it was asking for a re-cementation. If we have a look very carefully at this, it looks actually reasonably healthy. I know there's a little bit of erythema around here, but everything works. It's been in the mouth for many years. And this is one of those things that shouldn't actually work. And this is what I mean about things being out of control. You can never tell what will work and what won't work with patients. And if we have a look at this is the gentleman, what it was actually put on, these are healing abutments, and these healing abutments have been screwed onto the implants and then adjusted to make them parallel, and a bridge made on top, or a removable bridge made on top, and then cemented. Now, this actually shouldn't really work. And so if I did this on one of my patients, guaranteed it wouldn't work. However, if you look at the radiographs, the bone levels are well beyond the implants up into the healing abutments. So something that shouldn't work does actually work for this patient, but we can't actually classify this as, yes, it will work for every patient that walks in through the door. So we always try and stick to proven principles and treatment plans and techniques. Like Rudy Giuliano said, hope is not a strategy. I do not hope that all my work will succeed. We need to have enough bone for implants. And when there's limited amount of bone, like in situations like this, what do we do? Now, this is a gentleman that I again treated who was a smoker, and he had sinuses right up to the midline. That's the incisive canal there, and his upper denture was supported by 2 failing canines. Would he stop smoking? No, he was quite honest about it, but he did have implant in the lower jaw helping retain a lower partial denture. So we came to an agreement that he would stop smoking for a certain amount of time, and the only way I could see this besides zygomatic implants was to do some sinus lifting, both sides bilateral. So we did, in a conventional matter, lateral window, and just put in a bucket load of bone, autogenous and allograft. And you can see how much bone we built up from the midline all the way to the premolar sort of 6 area. Now, these are his lower implants. They seem to be functioning really well. And what we were able to do is get an awful lot of bone beyond the envelope there to stabilize our implants. We placed eventually a removable denture, implant retained removable denture for cleansing purposes for him, and he was absolutely happy with that. So some things that should work don't, some things that shouldn't work do, and I can't tell which ones are which. But we have to stay with our principles and work with them. Now, the good and bad of IFAL. This is another chap who came in for failed implants, loaded implants connected to teeth, an awful lot of bone loss around the implants. And this was, I think, 2016. We had limited options for him, but he wanted something fixed. He didn't want removable dentures. So close-up shots of the implants and the investigation showed that we'd completely lost an awful lot of bone around these implants. There was no option but to remove them. But then I thought, well, could we potentially give him a conventional all-on-4 as a staged approach? So in this situation, we removed the worst of these implants and did some socket grafting to allow things to heal, kept strategic teeth and implants. And if I just move this out of the way to show you, and we plan things digitally, the distal ones, the anterior ones, and we got a situation where I thought, well, actually, this might work. We've regrown some bone in the areas where there's bone loss, and it looks like we can have a conventional all-on-4. And here we are, 9 years later. I still see him regularly. Every 6 months, actually, comes with hygiene. And we've got a fully functional, full arch bridge, well designed, spacing between the implants, and it's clean. These implants down here are suffering, and we're looking at replacing them at some stage. But I'm not too worried about treating him anymore because we've seen success in his case. So with the treatment planning, we go through consents, photographs, We plan tooth by tooth assessments. I get a periodontal assessment from my periodontist to ensure that I'm actually doing the right thing and get a backup, really, because I can get blinkered. We can all get blinkered in our treatments. So it's nice to get a different view to make sure that the teeth can't be or can be saved. So we have this immediate full arch loading consent form that goes through all the teeth, all the options. It's quite comprehensive. They have a treatment summary. So this is to give to the patients, and it goes through stage by stage, pictures, they can see what they are getting, but also it tells them about the aftercare, because a lot of these cases, this discussion seems to stop at we're going to provide the bridge and that's it. But for us, it's more important that they realize that this is not the end of the road. They're not getting teeth, and they need to have continuous maintenance, even though they're not teeth. So also there will be a cost for this, and potentially refurbishment of the bridge, depending on the type of bridge that you have. The other thing that we need to measure and maintain is the transition line. If I just get these out of the way, some people have low lip lines, some people have medium, and some have high. And what treatment option are we going to have when we're dealing with these sort of things? Now, I'll move this out of the way. One way that we can do this in an analog fashion is we take an impression and make a soft suck down. Then with an indelible pen, 2 millimeters underneath the smile line, we make this little line here, and that's where we put our radiographic markers. This is just GP, and then get the patient to wear this for the CT scan. And what we get on the CT scan are these radiopaque markers exactly 2 millimeters below the smile line, so we know where the implant should go, so we don't end up in situations like this where the planning has gone wrong. So we know how much bone removal, and it gives us an idea of, is this the right treatment? Should we be doing this? Will there be too much bone removal? So going on to the cases, there are three. There's one provoke, one's evoke, and one is a 50-50, did I do the right thing or not? So this is the provoke one, where it might be the right thing to do, it might not be. I'd like you all to comment to see what you think. This is a 68-year-old lady who came in. She was an ex-matron, so she came in with definite ideas, and she requested an all-on-4. And she came from, there was an asthma fair in Cambridge. So she came from there requesting her all-on-4. There must have been a stall or something. She hated her denture, but she had a deep overbite and overjet. This is her. So this is her resting height, and this is where I wanted to rebuild to, an increased vertical. We wanted her to improve the appearance. And did my thoughts correspond to her views? And I remember from my restorative teachings, Dawson always said, when the muscles and teeth are fighting, the muscle always wins. So we need to make sure that she's comfortable, everything's in harmony, and there's not a fight going on in her mouth between the teeth and the muscles. So our discussion went from mounted models, intraoral, home try-in, which I'll show you in a minute, the consent form for various materials, and then the post-op maintenance. We go through this with our treatment coordinator as well about home diets, which is soft, mouth guard, hygiene visits, regular reviews, refurbishments, everything. So she's fully aware. We don't rush into treatment too quickly with these people. Now, the biggest problem, as Josh Bernard-Shaw said, with communication is that the illusion that it's taken place. By that, I mean, what I'm talking about, does the patient actually understand? And what they're requesting, do I get it as well? Do we have that understanding between us? So with this patient, there's a deep overbite. Now, there are teeth here that admittedly are restorable and can be saved, or these ones can. We have a discussion every year when we run a course about this. But what we did was increase the vertical, did a diagnostic. We made an acrylic temporary try-in. And you can see here how much anterior movement we need for these lower incisors, about 7 millimeters from their original position, to get the right vertical dimension. Could this be done by putting restorations on these? I deemed it not so, which is why I aim to sacrifice these teeth for a bridge. So we gave her this to take home and just to try in every now and again to have a little look to see if she was happy, if it felt comfortable. And then I did my surgical planning. with my usual software. This is what it looked like in the mouth, from her deep class 2 div 2 to what I would like to call almost like a class 1 with an overjet and overbite, which is acceptable, and a massive increase in vertical. But we tested it first with this because it's a huge jump from what she had to what we've got. And I wanted to make sure she was happy with it and was comfortable. And that's exactly what we did. We converted the plan to surgery. These are the pictures on the day of surgery, just to show that we got everything just as planned, even the slight offset with the midline. And she was quite happy with that. And that was what, 2015, 2016, I think the date was. So for our surgical procedure at the time, we were doing bone supported guides. So we have our lab create denture, our guide for multi-unit abutments, the impression tray, the wire. These are the surgical guides for each drill, and everything was based on the surgical planning. Now this lovely photo is donated by good friends of mine in France, Leon Parente and Karim Deda. Basically, the guide that we use is still a guide. People forget that it is a guide. You still have to use clinical judgment and understand three-dimensional positioning of your implants. So you can't put the guide in and just inadvertently just drill and forget about it. It is guided, not blinded surgery. So yeah,
we've been asked how what are the main factors to consider on how much bone you're going to remove at the time of extraction and placement?
That's a great question actually, but this goes back to the slide where we plan the transition line. So if you're going for an FP3, we want to know where that transition line, where the restoration will end, and that's how much bone we need to remove in terms of vertical. Buccally, I'm always about grafting it, so it all depends on the type of restoration. If you're going for an FP1, then you're not really trying to remove bone. You want to put the implants where the teeth should be and then create papillae with interpapillary bone. FP2, the bone might have already been lost, but you're still trying to create papillae. So in FP3, you're just trying to remove bone so you can get that transition line, that smile line of the prosthesis underneath the lips, so it doesn't look like they're wearing a prosthesis. So that's guide you. Now, where is that picture? I'll show you. I'll go back to it. I'll find it somewhere. It's with that guide. So you need to know how much bone you're removing. So is it around here? Yeah, it's about removing enough bone that your prosthesis, if it's an FP3, is hidden. So when they smile, you don't see that join. I hope that answers the question.
Fantastic, thank you.
So the guide was placed, we lifted the full flap, bone supported guides, protected the mental nerves, and placed the implants. The provisional bridge was then placed in 2013. So it's been going for a little while. Now, if we look at the upper jaw as well, an argument could be made for doing exactly the same in the upper jaw, because what's the prognosis of these teeth? They're post-retained, that's a canine. Post-retained canines we know don't work particularly well, especially in a class 2 div 2. There are posts everywhere, but I'm not crazy. I'm a restorative dentist. I'm not going to just replace everything with implants because everything has a time limit. So we decided to keep these. Everything was functional. There's no problem. But the most important thing, anyway, back to the provisional bridge, is how it's made and how it reflects on the gum. And we need everything highly polished. The gums heal. Definitive bridge was placed later on in 2013. And again, the upper jaw is fine. Now we see her every year. And I saw her recently for review, and you can see on the upper jaw we've lost a couple of teeth. Strangely, not the canine, but the lateral went, the bridge on the upper right went, and we replaced those. But the main thing is she's still got her teeth. There's an element of proprioception with these, so I'm quite eager to keep teeth, and the lower bridge is functioning really well. She's incredibly stressed at the moment, and she's regularly fracturing the prosthetic screws in this bridge, which we replace. Thankfully, the bone levels are staying the same, but each patient that we treat gets a splint, and I'll go through that in a minute as well. But with our post-op follow-up care, we review in a week, we review in 2 weeks for suture removal. We keep these patients really tightly associated with the practice. So we have hygiene every other month. I see them monthly. We have hygiene every other month, and that's the training purpose. This is to train them to maintain their oral health and cleaning around these bridges. We supply them with, we actually just give them an electric toothbrush and a soft head. We give them everything they need, almost guilt them into trying to keep everything clean. After the bridge is removed and the suture is removed at 2 weeks, we also give them an air flosser, a water pick, an oral irrigator, because they find that's really good to help flush underneath the bridge. And we continuously check the occlusion every 4 to 6 weeks. Now, number two, our second case, this is the evoke one. This is to evoke emotion because we did something nice for someone in 2015. This was our charitable case. We used to every year when we were Devonshire House do a charitable case. Basically, we just did it for free for people who really couldn't afford it or were in real trouble. And it was a lovely thing we did over the years. And we did it every year. So we had hardware donated by various implant companies, Nobel, Straumann, Neos, they all did it. We donated the time, laboratory costs, everything, but we kept everything in-house. We did it for the patient. We didn't put anything on social media because we don't think it's about that personally. It's about doing the right thing for us. So these quotes here in blue and in red are from the patient. And basically her feeling was that she could no longer carry the shame of her teeth, and that was her burden. She was referred. She was considered for our yearly case. She said she had an extremely miserable, pathetic life, history of bulimia, which was treated, and she had repeated dental treatments. I'm sure most of you have heard of the restorative spiral. That started in 1989 to 2003, where treatment was done, it failed, more treatment was done, and every time it ended up with tooth loss. So her complaint was unable to use dentures. She was on baby food, didn't eat in company, couldn't laugh, lived in fear about losing the only teeth that she had left, which were her anteriors. Single 15 years, she just lives in shame and deep-seated emotional damage, focusing on her mouth. It was a really sad situation. This is her picture. This was me forcing a smile out of this lady. 45-year-old, very young, non-smoker, extremely fit. She's a marathon runner. She suffered bulimia because of her high-stress career and had a poor nutritional intake, high sugar because of the marathon running. So she has her own transport. She has a much less stressful job. She's a regular attender. And the one thing that really got me, and I thought I want to treat this patient, is that she likes structure and rules to live by, which is great because I can tell her exactly what we need to do, what she needs to do, and she will follow it. And she's in a generally much happier place in her life regarding bulimia and regarding herself. So she was ready to be treated. So we decided this would be a great case for us. Her history, dental history, perfect teeth, 68 to 89. And then the bulimia started with erosive wear. And back then it was the usual gold palatal veneers, mouth guard, crowns, but repeated visits ended up her losing a lot of teeth. And then this is her. This is what she normally looked like. This is me forcing a smile. So she had a little bit of loss of her lower face height, loss of cheek support, lip support, and a low smile line, which was always a benefit. In her mouth, this is what it was like. She postures forward. She's got a canine, a couple of incisors, these lower anteriors, not healthy. And this was her only comfortable position. This is with her outer dentures, kinetic class 1s, poor crown margins, mucosa irritated around these crowns, and a lot of bone loss posteriorly, vertical and horizontal bone loss posteriorly. And I was at a loss when we took the scan, thinking, what are we going to do here, especially in the lower jaw? We can see how much bone loss there was. Remember, this was 2016. So looking at the CT on the lower right-hand side, the mental nerve was pretty much on the ridge. She was getting pain from her denture by compressing the nerve. And the same on the left. It was pretty much on the ridge. So it was difficult surgery. It's dangerous surgery from my aspect. But we went through all the options, replace all the restorations, try and get some sort of restoration that's removable. Essentially, she wanted to restore her wide smile. She didn't want anything removable. and she wanted to function normally in public. So I thought, well, let's try it. Let's scan it. Let's see what we can do. And I seem to be able to get implants in the jaw without it being exposed. And you can see in this sort of situation here how much bone loss there was around these teeth. But it seemed to work. We could just about squeeze in implants, 6 on the upper, 4 on the lower. And this is exactly what we did on day of surgery. We planned it. I'll just get this picture out of the way. We planned the upper jaw, 6 implants, 4 on the lower, and converted to a denture, implant retained prosthesis. And she kept going. And we reviewed her in 2022. This was the last OPG I took of her. I have reviewed her this year because she comes back every 6 months and everything's functioning really nicely. And what's lovely is her comments. You know, she feels like she's got her mouth back. I can't believe it's her mouth. It's changed her shape. And she even on the day of treatment, she even brought that tube of horrible stuff, she calls it, Fixodent, even though she was getting a fixed prosthesis because she couldn't quite believe it. And what's lovely is that never underestimate the power of a smile. And I phoned her a couple of years ago saying, how are things? I'm preparing a lecture. Are there any pictures of a smile? And she sent me this. This is her at an awards ceremony, naturally just smiling. She's in public. That's her upper, lower, and lower implant retained prosthesis. And she said, I'm back to being me. And it was lovely to see her relaxed in this sort of picture. And it feels good that we've given her this sort of confidence back from being from this situation to here. You can see how the lips are supported. It's a lovely thing to do. So the third case is, was I wrong? How did I do the right thing in this case from 2005?
Can I
This is still
interrupt you?
going.
Sorry,
Of
Whale.
course.
That
Yeah.
really nice case. Our young colleague Tom Murphy has asked, right at the beginning of the lecture, the large bilateral sinus grafting case,
Yeah.
where there was an overdenture given. Was this on locators or on a bar? And
I
what influences your decision on making this a RP1 or an RP2?
this was on a bar. I don't like giving locators in maxilla, especially in grafted bone. And with this chap's history, he's a smoker. I wanted to keep things removable. He as you probably all, people who know me, I don't trust anyone basically when it comes to dental work. So I want to keep things safe. I want to keep things predictable, and I want to keep things in my favor. So with him, because it was grafted, and a lot of grafted bone, as you can see, I needed it removable, but stabilize the implants in terms of connecting them with the bar. So I went with that. And also I'm happy the fact that the hygienist can remove the denture, clean around the bar, and with the bar, also with the design as we have I haven't got an overdenture picture here or with him, but we kept it clear of the mucosa, so 2 millimeters clearance of the mucosa, so we can clear underneath it.
Okay.
So that's how I went with that. Thanks, young Tom. Um,
You'll love
uh,
that.
yeah, I've got a picture of Tom later on. So this is a case that we could all discuss whether I was wrong or right, and would you do things different? I think if I were treating it today, I don't think I'd do it differently, to be honest with you. But
Sorry, Whale. Also, Gordon asks for case 2. Prior to surgery, did you confirm the new bite with the dentures?
with the dentures in case
In
2.
the one that we've just done.
Oh, this one. No,
Yeah.
we didn't confirm the bite with the denture at all. We went straight in for surgery. I chose the vertical in terms of, well, when we did it, we sort of did a bite registration at the new vertical and mounted at what we wanted to determine the height that we thought was right based on the freeway space as well, and then decided that way.
Okay.
I hope that answers it.
Thank you.
Where are we? Here we go. So case 3. 55-year-old, this lovely gentleman, extremely busy, medicated, high blood pressure, barrister. I don't know why that's in red highlighted and with exclamation mark, but we certainly went through our consent forms very carefully with him. But the good thing was this guy was a non-cigar smoker. Now, it sounds a strange thing, but I did say to him, do you smoke cigarettes? And he said, certainly not, young man. I'm a non-cigar smoker. He's a very posh chap, lovely. But the good thing with this chap, even though he said he was extremely busy, his son played football with my son. So I knew I would be seeing him every 2 weeks on a football pitch. So he couldn't escape me, which was the main thing. I don't like it when people are busy because you start treatment and then we lose them. Now, funny enough, this was his OPG in 2005, and he had two contacts in his mouth, one on the right, on the left-hand side, these premolars, and one on the right. And you can see what's going on here. Now, this, was I wrong or was I right? Should we have removed all these teeth? Should we not? What do I do? So I staged it. At that point, 2005, I was a restorative dentist. I wanted to keep teeth, and I still do. We can see caries down here on these teeth, and I thought, no, I'm going to save them. So lowers, we placed implants, and I loved endo at the time. I still do. So I root filled all these. Then he disappeared. He actually disappeared from sight for 5 years or longer. And he came back. And when he came back, there was caries all around here. So I removed them all. And we ended up doing bilateral sinus lifts and placing implants per teeth. So not an FP3, I wanted FP1, porcelain. I didn't want to remove the bone, and we wanted to put them in exactly the right place, but to also make sure that we're getting the right vertical. We went old school with this, with the verification jig, but also making, I'll just move these so everyone can see, making a verification jig and checking the vertical dimension on this jig, and then relining it with Tembond to make sure it's absolutely accurate for the mounting, and then making sure that when everything was fitted, it was cleansable. And this was a lovely picture donated by a good friend, young Tom Murphy, Esquire, showing how to clean with all the let me just get these out of the way, all these TP brushes. So thank you, Tom, for lending me this photo, because it occurred to me I don't have any photos of bridges being cleaned. So we go through quite thoroughly how to clean bridges with floss, with super floss, with TP brushes. But this is his porcelain fused to metal work. And through all of that, this is the whole trust issue, is with all of that going on, he still can't seem to clean that lower incisor natural teeth, which is a real shame. So radiographs, this is where I want to discuss, was I wrong or was I right? Treatment over 18 years. So we placed the implants in the lower jaw, they still maintain, we did root treatments, everything was lovely from that aspect. 4 or 5 years later, again, implants are looking good. Bone levels are great. We're all happy. And then he disappears again, another 5 years later, still okay. Everything's stable. I'm very happy. And then, now 18 years in total, now 11 years later, he's come back. Lowers are fine. And look at the uppers. I don't know if you guys can see this, but there's bone loss appearing around all these posterior implants. Now, I don't know why this is happening so late, but this bone, this grafted bone in 2003, I was just placing at the time, as we were told, BIOS, so xenograft. Great material, but now I'm mixing everything with autogenous. I want more autogenous bone than xenograft. So we're dealing with this now, and I think I'm concerned long term about implant work and these sort of prostheses in terms of making them cleansable, maybe removable, or how do we maintain them? But it also shows that, was I wrong doing this, knowing he was busy and he wouldn't return? Should I have changed the prosthesis into something that was removable, something that was easily cleansable? I don't know. Would I do the same nowadays? That's for us to discuss later. But everything that looks lovely, as we showed there might be something rotten underneath, and we don't know. So we need to follow up, and we need maintenance protocols for these patients as well. Our complications are mainly planning, but in the provisional stage, if there's any paresthesia, pain or swelling, I always tell them the speech will change. They will lisp because we're changing the teeth that they have to a thicker type of bridge. Aesthetics, is it right or wrong? Is it aeroscape? Occlusion is something that I grab hold of really tightly and check and make sure that is okay, because that's one thing that will cause issues. The problems we're seeing now is this. I love this quote. It's from Abraham Maslow. When you're a hammer, if the only tool you use a hammer, you tend to see every problem as a nail. So if you're an implantologist, there are other options. You don't need to be placing an implant per tooth. And we see this happening. Is this really required? Lack of space. We get an awful lot of issues with an all-on-4, an FP3 pretending to be an FP1, and the material is not thick enough, that we're getting fractures. And the implants are placed for an FP3, but essentially in the wrong place, so it can't turn into an FP1. It's all in the planning stage again. This was a case which is exactly that. I call it the eyes bigger than one's belly. It was trying to do too much. This was a case where there was poor planning, poor execution, and poor results, unfortunately. So these are complications. This was done where a long implant was placed and the implant was used to tent the graft, and you can see what's happened. It's lost. Now in this picture here, this is a multi-unit abutment. In this bit here, this is a cover screw on an implant. So the implant's already in the wrong position and we've lost bone, and that's the implant surface exposed. So we can't use this in any way. So we decided actually this has got to be removed and replaced. So minimizing the treatment, I removed the implant. You can see it's fully integrated because they always do when they're wrong. And you can see the thread pattern, beautiful bone, lovely thick bone as well. So removed it, corrected it, and replaced the implants. Got the right angle for the multi-unit abutment and sutured. Now, I don't want people having to go because this is silk. I was working somewhere else, and again, I should have trusted, but I didn't. I trusted them. That's all they had. I do not use silk except to tie up clothes. So I usually use pre-TFE or something resorbable. But you can see now the implant still, for me, in the wrong place because this implant's a lot higher, even though that's in the right place, but we've had to place this where the bone was. So it's a case of planning correctly and not doing too much all in one go. Trust no one, as my motto is. The return of old habits. This is again one of my patients where an all-on-4 was placed in 2015, a smoker. And I generally don't treat smokers until they can prove for 3 months that they haven't smoked. And I'm generally quite blunt with patients now, and I'll look them straight in the eye and say, do you smoke? And if I can smell it, I will say, look, we'll be honest with each other. I'm trying to help you and I'm trying to take care of you. So are you smoking? So this patient stopped smoking. We placed the all-on-4, reviewed regularly, 2021, absolutely fine, looking good. But then she came back a couple of years later. She'd got depressed, started smoking again. And the weird thing was that she was so scared about losing her implants that made her smoke more. Doesn't make sense. But then we started to see bone loss around these implants, quite a lot of bone loss, which is a real shame. What do we do in a situation like this? Well, it's difficult because that's a roughened surface that's exposed to bacteria. Can we truly get it clean? Should we use lasers? Should we use various types of galvosurge materials? But what we do is I see them regularly. We remove that bridge. We remove the framework. We use airflow. We use cortical gel, dentamycin. We retreat in 2 weeks. We retreat carefully, trying to change that biofilm in that gingival cuff to try and get everything smooth, healthy, and clean, and get the gingival cuff to be tight again. So we'll continue doing that until we see some sort of change. But then it's continuous, this cleaning issue. Can we trust these patients to maintain their bridges? Do we make the bridges cleansable? The design, is it right or wrong? We try and get our bridges like this, so there is a flossing channel, cleansability. Yes, they will get debris caught in there, but they can at least easily clean through them. So we don't end up in situations like this, where there's debris caught in these bridges. Though you can see the design is quite poor because it's concave instead of convex. It should be smooth, convex surface where nothing collects, a bit like this. And then bruxism. I believe truly that there is no pre-treatment may not be a sign they have loose teeth, but after treatment, when we're giving them something fixed, people turn into bruxists. Okay, they lose teeth. There's no sign during the provisional phase because they're on a soft diet. Patients are very careful. But I feel that generally when we fit a definitive bridge, there's a lot of wear and there's a lot of bruxism that goes on, which is why I try, if we can, try and save teeth, try and give them a couple of opposing pairs of teeth for proprioceptive needs as well, and maintain the vertical. But every single patient, we give a Michigan splint. So at the provisional stage, I give a soft suck down because I can make that initially on the day in the lab on site as a protective procedure. But for long term, the definitive bridge, I always give a Michigan splint. And it's the easiest one that I ever fit because it's made outside the mouth on the bridge and then given to the patient. So it's absolutely ideal. So what have we understood about IFAL, immediate full arch loading? It's a viable treatment option in selected cases. Definitely need a lot of education and mentoring. I would make sure that if you're getting into this, people need a lot of mentoring beforehand because it's a difficult one to plan to get right, especially for FP3. It's difficult to execute properly. We need a backup plan and very strict maintenance. Um, but the bone quality long term, we need to think about. And do we need to graft? How much do we need to graft? And what aspects of are and are out of our control? And remember, with these patients, we only see them every 6 months, maybe a year. We do not know what they're doing outside of our surgeries. And we have to trust patients with all this wonderful stuff that we all produce. We do this lovely work and then we give it to them to take care of. And that's where my concern is. But also we've got to look at ourselves and are we doing the right thing? Do we have what I call expert induced amnesia? You do something for so long and practice for so long that your responses are automated. So you don't actually know why you're doing it, you just do it. And I always like to say that not every space in the mouth is a titanium deficiency. There are other options. We need to think about what other ways we can fill that space besides titanium. So I'd like to leave you with one little message is tell me and I forget, teach and I remember and involve me when I learn. And that's one way we sort of try and help everyone, especially in VSS. We try and involve people and make them, understand what we're doing, make them into better clinicians. And I would like to also I'll get that out of the way, thank VSS for the honor of being able to speak at one of your implant threads. Thank you, Fadi, Alan, and Amy, and obviously John, who's taking the session now. Thank you ever so much for asking me to speak, and thank you everyone for listening. So I'll leave you there. A little bit early, we rushed through it, but for any questions.
Sure. Thank you for that, Will. That was really interesting. It was fantastic, and thank you for putting up with IT issues.
Sorry,
young Tommy Murphy's asked again. So he says that there is a trend of full arch cases where photogrammetry is being used. The definitive zirconia bridge is being made direct to multi-unit without a TI base. The logic is that polished subgingival zirconia is tissue friendly, and there is a level of inaccuracy for cemented tie bases. What are your opinions on this regarding long-term risks, e.g. fracture, low temperature degradation, thin cross-section to engage screw heads, etc., zirconia versus metal for nanoparticles moving into tissue? Fadi's favorite thing. I'm sure Fadi's in the background, so he'd love to comment on this as well if he'd like to.
Right, I've stopped sharing. Am I back on?
Yes, you are.
Thank you, Tom.
And if anybody has any more questions or anything like that, please pop them in the chat and we'll get to you as soon as we can.
At the practice, we're still tending to favour hybrid bridges at the moment because they are extremely easily repairable. We're very lucky to have a bridge on site, a lab on site to repair our bridges, and we always keep the provisional ones. We've made a few zirconia. I know photogrammetry is the way to go. When we do our courses and when we start teaching, we always teach from the analog point of view first and then move on to the digital, because I think it's important that people need to know and learn the analog aspect, how it was done, and then move on to digital. So in terms of zirconia, polished surface definitely obviously the way to go. It's far better than the glazed against tissue, absolute tissue level. Against, I don't know if I understood the question properly, but against straight to implant surface, I still like metal against metal, as in titanium against titanium, not zirconia against titanium. I think there is an issue with wear and potential fracture on that. With the implant sizes, I'm always wary of narrow ones, got to be honest. If they are narrow, I try and put more in to spread the load a little bit more, and also the connection with that bothers me quite a bit. Whether it's old school or not, I don't know, but I quite still like decent size implants, a lot of bone around them, and always err on the side of I plan for failure. Basically, I've got a plan for failure. So zirconia bridges, absolutely, if I was going to do it, it would be photogrammetry. I think it's very accurate, extremely accurate. It's the way to go. So I hope that answers some of that very long question that Tommy asked. But yeah, but the majority, honestly, the majority that we do at the moment are still hybrid. And we're seeing from that, my aspect, we are seeing still a lot of wear on them. And my concern with zirconia being such a wonderful, beautiful, hard material is what's happening in the opposing jaw, and the pressure they put on the bruxism, because I do think there is a lot of pressure when they lose their proprioception. What happens? And they're not easily repaired. So, and is there enough space? That's the other thing. Is there enough space for connectors? Is enough space for material? I've seen cases where zirconia bridges are being offered and the planning's wrong. There's just not enough vertical as well for connectors.
I mean, I've seen it with zirconia crowns on natural dentition sort of wear on opposing arch as well. And after sort of 4 or 5 years, that we're sort of seeing, cusps being lost, or fractures being lost as well, and that's with proprioception on top.
Well,
so no, I completely agree with you on that.
It does bother me, not just the material, but it's the procedure. It's this craze about doing full arch immediate loading, or immediate full arch loading. There's I see more and more practice just offering that, and I think, are there really enough patients in the world or in the area that warrant it? I don't know if there is. And if it is all FP3, then what next? When and it is when, not if, it's when things fail. Where do we go? Are we qualified to be doing zygomas or pterygoids? And there are some absolute, don't get me wrong, there are some absolutely brilliant surgeons out there who do some amazing work, and they take care of they're so knowledgeable. They take care of the bone, they take care of the thickness, take care of teeth, and their results last, and they last a long time, which is great. And they're the ones we should be learning from. But I think people are getting into it way too quickly and need to go on proper training courses with people who have been doing this for decades, and question them about, well, how does it work well for you? Why does it work well for you? How can I get the same? Not just jump on. And I've had people, sad to say, people have sent me, messages saying, could you mentor me for all on four? I've done, I've been qualified 5 years. I've done implants for the last 2. No. Go on I always say, do a couple of hundred implants, then go into sinus lifting and soft tissue work before you then get onto something more. Just take your time and learn the profession thoroughly, and also learn how to deal with your own failures before you move on to something you can't deal with. I always used to say, do the procedure that you can repair there and then. So if it goes wrong, you know how to deal with it. So you need to be at that level. And if you're not, then you need to be doing it with a mentor by your side. So if it does go wrong, there's someone there that you can learn from that can also fix it. So you need to be better than the procedure that you're doing.
It's good advice. Good advice. We've been asked, what are your thoughts about soft tissue grafting around all on fours? Thoughts and opinions for long-term success improvement.
Well, I'd always go back to that lovely book by Linkevicius. You need a good 2 millimeters of bone. You need a good millimeter and a half of tissue. You also need keratinized mucosa. It is imperative that we have keratinized mucosa around the tissue. It's whether, depending on the type of flap that you do, can you manipulate it, or do you, on the lower jaw, can you do a free gingival graft to increase? The thing is, we need to increase the thickness of the tissue, and we need to increase the keratinized mucosa around them. So, which is why I said, even in your training, before you get onto all voice, learn some soft tissue work, learn how to do this sort of stuff. And in situations where there aren't, then maybe do that first. So in terms of soft tissue, yeah, I think it's highly important. And remember, I grew up in the era where bone was bone. There wasn't any talk about soft tissue. And if you get bone, squeeze an implant into bone, you pat yourself on the back and think, well done me. And we didn't think about it long term. And that's completely changed in terms of soft tissue is highly important. You can't go to an implant lecture nowadays where soft tissue isn't mentioned in terms of getting it right and the thickness and the amount of keratinized. So yes, it's important. Do we do it? Yes, we do. And we're doing it more and more, especially with immediates, grafting and connective tissue grafting at the same time.
Do you do it? Would you do it simultaneously, or do you often do it staged as well for your soft tissue grafting?
It depends also how much grafting I'm doing, because I do an awful lot of bone grafting. So the flat, I lift big flaps. I do bone grafting. So if I'm doing a lot of that, I know you can do it at the same time, but I prefer to do it separately. So I'll build up my bone first, let that heal, and then go back, do a split thickness, and then do sort of connective tissue grafting. Or situations where you might be staged, where I'll cover the implants and at second stage, then do a free gingival graft on the lower jaw just to build up the keratinized from that aspect. So you can't, I think what I'm trying to say is you can't just jump into getting the treatment done in one go. You've got to plan the case and think what's the best for not only the patient, but for us, because we have to deal with the complications. So what's best for us long term? And then I'm afraid that's how the treatment plan should go.
Yes.
The patient's coming to us for treatment, for the best results. They're not coming to you to say, do you know what, please can you give me a full arch set of teeth, and I don't really care if it works in 2 years or not. They're coming to you to say, I want something. They want the best that you can give. And if they're not happy with the type of treatment plan that gives you the best results, and therefore them, maybe they're not for you. So it's part of your treatment plan and planning. It's always down to the planning, making sure we've got each stage done right.
It's learning to say no to the patient, isn't it?
Yeah, well, learning to say this is what I'm comfortable,
this is what
I'm good at, and this is how it works for me over these many years. If you can't do that, then I can't treat it, because we're putting us in a very difficult position. Then we're doing something that we're uncomfortable with, which will ultimately fail.
Sure. What are your experiences on using tissue level implants for all-on-4s, all-on-6s?
Yeah, I'm not a great tissue level man, actually. Sorry for I'm a Straumann. I do use Straumann. Okay, so it's not a Straumann thing, but no, original ITI protocol with tissue level was you place it and graft. That was their protocol, and graft big around tissue level. I do use tissue level around the posteriors, molars, whatever. I don't mind, because it's got a built-in abutment and the metal collar can be saved. It's lovely, but is it better than anything else? No. So I don't use tissue level because I want some more flexibility in terms of, say, my emergence profile, the way I want it, and my multi-unit abutment. So no, we are restoring a few in a place that I work that I've been done with tissue level implants. We're finding quite difficult to restore, and also with those, there's an issue with, have people taken that polished collar, that soft tissue collar, into account when planning the restorative height? And more often than not, they don't. And then we're now compromised. So no, I don't. Bone level every time.
Every time. What's your opinion on stackable guide systems for full arch cases in terms of accuracy, since it's a bone-based guide?
Yeah, it is a bone-based guide. It's, if you've got the room, great. I haven't used them, I gotta be honest. I got a very good friend who uses them a lot. and gets great results from them. It is something I want to try. We go bone level with our guides, but also because I want to see everything that I'm doing.
Sure.
I'm a bit more of a control freak in terms of that aspect. So I need to see where my drills are going. I want to measure the amount of bone. I lift big flaps, and I'll put just a little story when I was mentoring an excellent chap in the Midlands for full arch work with a bone supported guide, and the distal implant was about 15 millimeters long, and the guide was used, and it was a perforation buckley. Yeah, because the bone was thin when you had to graft. So it was a perforation buckley. The good thing is we could see it. So it took over and it was placed beautifully, grafted beautifully, and it's still functioning now. That's the issue with guides. As you know, John, I don't trust anything or anyone, so I need to make sure that it works in my hands. I need to see everything. I think stackable guides work well. I think that's yet another way of getting things right, and it's safe. But again, just don't rely on it completely. Make sure, remember that guided blinded surgery slide. Make sure you're in control, not the guide is in control.
Sure.
And it's also make sure it fits. What if it doesn't fit? If something doesn't work, is there enough access? These are decently sized guys. They're big. You've got to assess the patient properly. Is there enough room?
Yeah.
For the guide and the guide on top and the drill and the handpiece and the long drill. You've got to assess all this. So yeah, it works for a lot of people, but when it doesn't, or where there's an issue, what do you do when the patient's sedated and in surgery? You've then got to rely on these.
Absolutely. Just ask it, if anybody's got any more questions, please pop them in the chat. I'm going to ask, in terms of sort of people wanting to get into full arch, and you said that, place a couple of hundred implants, get into sinuses, get into soft tissue grafting as well. What should we be looking for in sort of like in terms of a mentor for full arch work?
There is on the College of General Dentistry, there's a list, a mentors list, and on there that should say what they would mentor, what level they would mentor. Now, I think, like I said before, you want someone who's been doing this procedure for many years, not for 5, we're talking 10, 15, whatever. Someone who's been doing it for an awfully long time, and someone who's not afraid to show their failures, the things that they've got wrong and learnt from.
Yeah.
So that lovely chap in the Midlands, I went and mentored him on 5 separate occasions because he had the foresight and the knowledge of thinking, right, I want to learn this procedure, and realised that you just don't want to go on a 2-day course or a week-long course, or one of these courses where you do like 3 or 4 of them in a week and think that that's it, I've learned it. So it's a continuous learning process. So there's someone that's always available, someone who's happy to give you their time, even if it's just a general discussion, even a WhatsApp question, or someone that you can call. So someone who's available, someone who's done it for numerous years, and someone you just get on with. You just have that trust between the two. And the most important thing is open and honest conversations. And someone you've got to be prepared. It's a hard thing to take, but you've got to be prepared for someone to say, actually, I don't think you should be doing this right now. They're not doing it to harm you, they're doing it to help you.
Sure. I think that's really important. I agree.
Mm.
On the point of planning for failure, Randa says that he knows that there's a systemic reviews comparing long implants to short implants. However, in your clinical opinion, what are your thoughts on using shorter implants, sort of 8 to 10 millimeters, compared to 12 to 15 for full arch surgery work? The reason being that if something fails, then you can utilize more native bone, etc. Is that overly cautious in your surgical opinion, or a safe approach?
I think, I mean, 8 is considered standard, right? But in the posterior region, you want something a little bit longer. I think 13 millimeters. The protocol, the original all-on-4 protocol that that Nobel came up with, Paolo came up with, is 13 to 14 millimeters for distal implants for that, and allowing distal cantilever. So anteriorly, it doesn't matter.
Okay.
Even Paolo said that anteriorly doesn't really matter whatever's length, but you do need longer ones. And at the time, it was also 4 millimeter diameter because they were using Brånemark or the Speedy Groovies. Now they brought out Conical Connect for Nobel, that is, which is 4.3, so that's the standard implant. So normal 4 millimeter diameter, 13 to 14 millimeter distally if you can. If not, if you're going shorter, I would be personally, I'd be a little bit more concerned, and I'd try and see if we can put further implants in to stay to distribute the load better, or maybe change plan completely. I don't want a procedure to fit the patient. I want the patient to fit the procedure. So maybe I'm doing the wrong thing. Maybe I want to look at something else. So in terms of answering the question, distal, I still go long. Anteriorly, I'm not too bothered.
Fantastic. And then I'll just leave it for another minute for any remaining questions. I will just let you know that we do our next Implant Threads is going to be in 2 weeks' time on the 6th of December, and it's with VSSAcademy's own Zemin Chan, who is going to be discussing AI for dental practices, and the title is Work Less, Save More, Grow Faster. And it's to discover the latest AI tools that streamline daily operations, practical example-driven sessions showing dental professionals how to automate admin, reduce staff workload, cut operational costs, and improve the patient experience using simple AI tools. So I think that'll be a really good session for us to have. Anything that reduces my workload, fantastic. I'm well on that. So that will be the 6th of December, and all the links and sign-ups will be going on our usual channels and things like that. Can you have a transcript? I think we should be able to sort something. I know that we are looking at placing all the videos for Implant Threads onto YouTube, so you should be able to watch back on this. In terms of, we've been asked if copies of the presentation can be given out. Well, if you're happy with that.
I could send it to you, John, as a PDF.
I think I've already got a copy. I think I snuck one in the background. Yeah, I think it's on our Google Drive. So yeah, I'll leave it there and say thank you, Whale, for your time. It's been fantastic. Thank you
very
to
much,
all the delegates for turning up. It's been brilliant to see you all. And then we'll see you on the next one. Whale, if you could stay on the line, that'd be great.
Sure.
And then
Thank you very much, everyone. Thank you for
we'll see
listening.
everybody at the next one. Take care.
See you guys.